residents or postgraduate students. The main work of our instructors is to answer students' questions like this. Professor Xu, my patient lost anchorage. What should I do? This is the issue we are going to talk about in this two-day course. First of all, I will introduce a new concept, physiological anchorage control. Let's start with mechanical anchorage control, which is well known by all orthodontists. It originates from the mooring of a boat after it docks at shore. When a boat docks, if we don't want it to drift away, we tie it to an anchor, right? If the drifting force of the boat is less than the load capacity of the anchor, then the anchor holds the boat in place, like this. Then we call it anchorage success. But if it's a huge ship like this, it may just pull away the small anchor. Then we call it anchorage loss. Now, let me ask you a question. Does orthodontic anchorage loss correspond to the small boat situation, the situation 1, or the big ship situation, the situation 2? Show your fingers, number 1 or number 2. So I see all number 2 situation. But if we think it deeply, if orthodontic force is large enough to pull anchor tooth away, you still think it's anchorage loss? It's much, much more than anchorage loss, right? It's like surgical extraction of tooth. So orthodontic anchorage loss is actually corresponding to the situation 1, after mechanical anchorage is successful. Anchorage loss is the story that happens after mechanical anchorage is successful. Let's look at the story after mechanical anchorage is successful. When the orthodontic force is less than the load capacity of anchor tooth, the tooth is stable. But the pressure on the periodontal ligament will induce osteoclasts and osteoblasts, then causing alveolar resorption and apposition, right? Then anchor tooth move, which is when we call it anchorage loss. But is anchor molar move the cause of anchor molar move only by mechanical force? Yes or no? No, because when tooth growth and development, it also moves, right? And tooth growth and development also associated with jaw growth and development. So I draw a red line here. Before the red line, I call it mechanical anchorage portion. But after the red line, it's more complex. It involves bone metabolism, growth and development of jaw. So I call it physiologic anchorage portion, which is the part we orthodontists need to learn deeply. Mechanical anchorage loss is understood by the general public. It's just a matter of bigger tooth over smaller tooth, more teeth over less teeth, right? But we orthodontists are professionals. We should know more about physiological anchorage. If you can understand this causal relationship diagram of anchor molar displacement, your knowledge about anchorage control will be raised to a higher level. For example, if we can invent a biological agent that could drop into periodontal ligament, like the iodine glycerin, that can stop the formation of osteoclasts and osteoblasts, then do you still think the anchor teeth can move? No, it won't move. It will just function like implant anchorage. Why implant anchorage is stable? Because no periodontal ligament. So no osteoclasts, no osteoblasts to resorb or absorb alveolar. That's why implant anchorage is so strong. So anchorage loss does not equal to the force magnitude. But blocking this pathway has not been realized. The pathway we are working on is this one. We try to use this pathway to control anchorage. I call this PASS. It's the acronym of Physiological Anchorage SPEE-WIRE System. So we will introduce this method in this 2-day course. If we want to know how to use tooth growth and development to control anchorage, you need to first know how tooth growth. This is the study done by Professor Gu, vice chair of our orthodontic department, and Professor McNamara from Michigan University. They published it in 2008. They compared two superimposition methods. One on the implants, metallic implants, another on palatal plane. They used the American longitudinal growth sample with metallic implants. Same individual. When do superimposition on implants, you see molar growth downward and forward. But if you see the superimposition on palatal plane, as we usually do in clinic, you will see molar have no downward growth, only forward growth. Why is that? Because the reference structure by palatal superimposition changes. We all know there's a bone resorption on the nasal bottom and bone apposition on the oral roof. So if you align the black outline of the palate with the red outline of the palate, you actually overlook the change of palatal bone. So this is the real molar growth and development pattern, not this. Now you see molar growth downward and forward. If this is an extraction case, we extract 4 teeth, then use molar as anchorage to retract anterior teeth. Molar may move forward along the arch wire like this. After treatment, we measure molar displacement and say how much anchorage loss by measuring this one. But this part has nothing to do with orthodontic force. No, it's natural growth. So I call this part physiologic anchorage loss. Only this part is caused by orthodontic force. So I call this part mechanical anchorage loss. You may think, why should we differentiate physiologic anchorage loss and mechanical anchorage loss? Let's look at them respectively. First, mechanical anchorage loss. It's related to action and reaction. Every orthodontist knows that. How to deal with reaction? We use TPA or lens arch to disperse the reaction on molars. We use headgear to resist the reaction on molars. Or we use TAD, the implant anchorage, to detour the reaction to mini screw. So the strategy to prevent mechanical anchorage loss is when there's a mechanical force, we take a measure to resist it, right? How about physiological anchorage loss? It's invisible. Out of contemporary orthodontic concept, few orthodontists are aware of its existence. When I say few, it means still some, right? So who knows that? Orthodontic researchers, like Professor Lau Johnston. He's a very famous scholar in orthodontics in the world. In 2014, he visited our department and had a 1 week with our team. During that week, he gave a lecture every day to our residents and faculty members. One lecture is about how molar moves with growth. He used a longitudinal growth sample from Case Western Reserve University that observed from 5 years old to 16 years old, 11 years. He measured upper molar growth within the maxilla and lower molar growth within the mandible, and measure the mandible outgrowth maxilla in sagittal direction. He found upper molar move forward approximately to the mandible access to maxilla. So from this study, you know upper molar move forward with mandible growth. So not just because of reaction force from appliance, it's also from natural growth of jawbone. Now Johnston used this animation to describe the growth compensation model. He said with mandible growth forward, by the intercuspation, it will push upper dentition forward like this. So the concept of physiologic anchorage is molar mesial movement by biological force, the growth of mandible. Nothing to do with reaction force by our orthodontic appliance, and probably exists continuously during orthodontic treatment. Since it's a continuous biologic force, so the strategy to prevent physiologic anchorage loss is continuous force or other measure to resist it during the whole treatment period. You may think biological anchorage loss is induced by very light growth force. Would it be possible it will be prevented when we put on the fixed appliance? Let's use Professor Gu's paper again. When we use straight wire appliance, insert a straight wire and engage inside the brackets, molar will get forward tipping moment. We have already known even without this moment, molar will tip forward like this. With this moment, it will just accelerate physiologic anchorage loss. So our conventional straight wire appliance cannot stop physiologic anchorage loss. What about adult patients? Well, we use Lau Johnston's animation again. This time, we separate the upper dentition into individual tooth. Then, when mandible grows forward, it may tip all tooth forward, tipping, right? Let's think about another scenario. In one case, it's a retrognaathic mandible, skeletal class 2. Another case, it's a prognathic mandible, skeletal class 3. What impact would that on the upper teeth? That was studied by Professor Su in his doctoral thesis. Dr. Su gave lecture 1 year ago. So you may remember her. Huh? This is her doctoral thesis. He measured 1,403 cases and found for class 2, upper molar tipped back like this. This angle is 77.5. But for class 3, this angle is much larger than this one, with statistical significant difference. What about in skeletal class 1? This study is done by Sichuan University. They published it in 2010. They used 163 normal occlusion case. But they compare the high angle, lower angle, and average angle. And found for high angle case, upper molar tipped back more. And lower angle case, upper molar tipped forward more. So even for class 1, skeletal class 1, upper molar also compensate to the vertical skeletal pattern. They are different. So in what cases upper molar tipped back more before treatment? From the study above, we now know upper molar tipped back more in adolescents than in adults. In class 2 than in class 1 and class 3. In high angle cases, more than in low angle cases. So in those situations, molar tipped back more. It also means when we use street wire, it's more prone to tip forward because street wire uses 0 degree prescription buccal tube. But those cases, molar tip back like those. That's minus degree, not 0 degree. So when you use 0 degree, you just accelerate upper molar anchorage loss, right? These are 2 cases from Dr. Su's sample. Now we look at the study cast. For class 2, upper molar tipped back like this. But for class 3, upper molar tipped forward like that. If upper molar tipped back like this, what do you think? I think it's more like anchorage preparation by tweed technique. But tweed technique, you need to use J-hook headgear to push upper molar back, right? But actually, for those cases I mentioned in last slide, a lot of patients molar tipped back naturally. So you don't need to push them back by J-hook headgear. So I call it anchorage reservation, not anchorage preparation. Preparation means we orthodontists need to use headgear to push them. But reservation means it's naturally existed. So our work is just to take good use of it. Don't waste it. In Dr. Su's another study find compared to treatment-related factors, patients' physiologic characteristics have a greater influence on changes in the angulation of upper first molar during orthodontic treatment. The more distally tipped the upper first molar are before treatment, the more they were tipped majorly during treatment. Thank you. So the new concept of anchorage is the loss of anchorage in molars consists of 2 parts. One part is caused by natural growth. That's physiologic anchorage component. And other part is caused by orthodontic force. That's the mechanical anchorage component. Orthodontists only familiar with the last one, not the familiar one. But after this course, you will know both. Second part, I will introduce how to prevent physiological anchorage loss. Our awareness of anchorage loss pattern affects our anchorage control method. If we think molar anchorage lost in this way, parallel movement, how can we prevent this kind of movement? We give a force at CRE, right? Center of resistance, to prevent the molar bodily movement forward, right? We can use a combined headgear like this to make the force go through the CRE of the molar. But if we think molar anchorage loss in this way, how can we stop this kind of forward tipping? If we use force at the CRE, can we prevent the crown forward tipping? No. So how can we prevent this kind of anchorage loss? Maybe we should give force here to the crown, not to the center of resistance. Or we may give it a tip-back bend. That's why we create this special buckle tube. It composed two tubes, one minus 25-degree round tube and one minus 7-degree rectangular tube. Two tubes across in the front. So I call it cross buckle tube, XBT. Why minus 7-degree? Orthodontists think the main tube should be 0-degree. Why we use minus 7-degree? That's because we did a prospective randomized clinical study 20 years ago. When I came back from US to China, 3M Unitech wanted me to promote their MBT appliance in China. Then I said, I have not used it before. Could you support me to do a clinical research first to see what's the advantage of your MBT system? So they support me to do a study. And we used about more than 10 years and published in 2010 in AJODO. This study compared two retraction methods, the traditional two-step retraction and unmasked retraction as MBT straight wire appliance advised. And this is the result. We see upper molar move forward 4.1 millimeter in unmasked group and 4.5 millimeter in two-step group with no statistical significant difference. Then we checked the angulation of upper molar. It tipped forward 7.4 degree in unmasked group and 6.9 degree in two-step group with no statistical significant difference. So we can pull them together. The average molar tipped forward about 7.2 degree. That's why that the main tube, rectangular tube, we designed as 7 degree. From this study, we now know the prescription of 0-degree buckle tube of street wire cannot guarantee a parallel movement of upper molar. We need a 7 degree to make upper molar keep straight. That's the average from this study. We can see molar move forward, but not parallel movement, not bodily movement. If we draw a line through the apex of post-treatment molar apex and parallel to the non-axis of before-treatment molar, we can divide this into a bodily movement like this and a tipping moment like this. And we know molar tipped 7.2 degrees. How can we know how much anchorage lost by tipping moment? Or 7 degree anchorage loss means how many millimeter anchorage loss? We can actually use a formula to calculate it, right? As long as we know the molar length, the average 19.7, multiplied by pi 3.14, multiplied by 7.2, and divide by 180. Then we know this is about 2.47 millimeter. Is 2.47 millimeter a big number? Well, it's approximately to 1/3 of bicuspid extraction space. That's almost the definition of maximum anchorage definition, right? It's less than 1/3 bicuspid extraction space is maximum anchorage definition. So if we don't let the molar tip forward 7.2 degrees, we can save 2.47 millimeter anchorage. That's why we make the main tube minus 7 degrees, not 0 degrees. How about 25 degrees, this one? Why we make this one? This one we need to use knowledge of biomechanics. You know the V-band mechanics. When we put a V-band in the center of two neighboring teeth, those two teeth get same magnitude but opposite direction moment. That is in equilibrium situation, right? But if we move the V-band off the center, this moment will become larger and this one becomes smaller. So the net moment is this one minus this one. In this case, the two teeth system cannot reach the static equilibrium. It needs one pair of vertical force to form a couple in opposite direction. When this couple equal to this one minus this one, it reaches the static equilibrium, right? If the V-band move to about 1/3 of the span, the arch wire may go straight or parallel to the slot through the canine bracket. Then the moment here reduced to 0, only this one. The net moment is only this one. To reach the static equilibrium, it needs a vertical force to form opposite direction moment. If we move the V-band furthermore back to the molar, within 1/4 distance between these two teeth, the arch wire may go this way through canine bracket. Then canine will get this direction moment, like this. So it will be same direction moment as our molar. So I call this when if we use the same angle of V-band, but in different location between two neighboring teeth, the moment will be different. I call this differential moment. And the larger moment dominates the fourth system, dominates the direction of the two teeth system. I call it dominant moment, like this one, dominant moment, right? So now we know when we use same angle but different position, the moment will be different. But in straight wire time, we are not bending wire. We just use straight edge wire. So for malocclusion like this, we do exactly the same thing. To insert a straight night-eye wire, right? In the beginning, first stage, we use night-eye wire to align teeth like this. But if you see the arch wire deformation like different way, it means what? It means the force system are different, not the same, right? But since we don't bend, we cannot use the V-band knowledge to analyze the force system. We don't know what happened on each tooth, because straight wire tell us we put the angle in the brackets. Now we know angle, but how about location? I just said the V-band mechanics, two very important factors. One, the angle of the V-band. Two, the position of the V-band. Now we know angle, but low position, right? Then how to use V-band mechanics to analyze straight wire appliance. Well, if we want to know the factor of bending position, we can think what bending position affects in two teeth system. Look at the full situation. When V-band move from center to close to molar, what changes in these four situations? The angle changes, right? These two angles are the same. When it moves to molar, this one becomes larger and this one smaller. Move to molar further, this one reduced to 0 degree. This one larger. And move to 1/4 within the closer to molar. This angle become minus degree, less than 0 degree. So the position of V-band actually affect the angle, the Y-slot angulation. This one. In that case, we now can analyze straight wire this way. We put a straight wire in and compare the arch wire slot angulation. In this one, which slot wire angulation is larger? This one, right? This approximate to 0. And in this situation, which one has larger wire slot angulation? Also this one, right? But the canine get opposite direction movement in these two situations. And this one, the dominant moment will be on molar. These two dominant moment on canine, right? I say larger moment dominant the system moment. So now we know the angulation of tooth will affect wire slot angle. That means the tooth with largest angulation will dominate the system moment, right? Then we will deduce a ridiculous conclusion. The malocclusion will dominate for system. Is that right? We think we orthodontists treat malocclusion. But the fourth system now is not controlled by our orthodontists. It's by malocclusion. How can we treat the malocclusion well? If our orthodontists don't control the fourth system, what will happen? Well, this is a crowding case. We use a straight 9-tie wire. Now let's analyze the 2-4 system. We draw a straight line and compare the slot wire angle. Which one is bigger? Canine, right? So the dominant moment is like this. And this angle is smaller, so the moment is smaller. Then the net moment, or the sum of the moment, is this one plus this one. It cannot reach static equilibrium. Then a vertical force, a pair of vertical forces are needed to create an opposite direction moment. This will extrude the canine. That's what we want. But how about this one? This will intrude bicuspid, right? That's not what we want. But whether we want or not, after 1 month, the canine extruded and premolar intruded. Then what will we do? We pull it back, right? That we call what? Round shape movement of teeth. Would that be high efficient? Certainly not. What's the solution? Well, we can either learn from edgewise bending tip-backs in front of anchor molar, but now orthodontists are familiar with 9-tie wire. We are not using stainless steel in first stage, right? The second one is following the approach of the straight wire appliance. We create a dominant moment on anchor molar. That's suitable for the properties of 9-tie wire. Now, how to create a dominant moment? If the molar tipped forward like this, the dominant moment is on molar. But usually, molar positioned like this, even tipped back a little bit. Then if we want the dominant moment on molar, we had to tilt the tube like this. That's why we make this minus 25-degree round tube. Because we want this angle larger than male-positioned tooth. Then we can make sure the dominant moment is on anchor molar. You may ask, what's the difference between T-PAC tube and T-PAC band? Well, they are similar in mechanics. The differences are the magnitude of the moment and the stability of the moment. Let's first look at the magnitude of the moment. Let's compare these two situations. This one with T-PAC tube, and this one use T-PAC band, traditional fixed appliance use T-PAC band. And now we use T-PAC tube. This one we use night-high wire. This one we use stainless steel wire. If we use the same size and the same degree, minus 25 degree here, also minus 25 degree here. Let's compare the magnitude of these two situations. We use Professor Burstein's paper published in 1985. He compared 3 wires with a 0.016 light-high wire and stainless steel wire. And this one is Chinese light-high. This one is American light-high. Now you can see Chinese light-high with lighter and stable force. Now, let's compare Chinese light-high and stainless steel. We find a 25 degree here. This is 40, 20, 30. This should be 25, right? Then we know the bending moment is about 700. This is 1,000. So here, probably 700, right? If we want to get 700 bending moment on stainless steel wire, what would be the bending angle? It's about 5 degrees. This is 20, 10. This is 5 degrees, right? So now we know 25 degree and 5 degree on stainless steel are equal. So if we want to get the same magnitude as this one on T-PAC band, we need to decrease this band, right? Decrease band from 25 degree to 5 degree, like this. But if we decrease the 25 degree to 5 degree, you will see the arch wire now below the canine bracket. If we engage the arch wire, what kind of moment the molar get? It will get a forward moment, right? So even the biomechanics is the same, but since the magnitude is much different, so it may change the direction of the moment on molar. The second, let's look at the stability of the moment. We still use Dr. Burston's paper. Now we use the unload part. We find a 70 degree here, and see for the Chinese light eye, the bending moment is about 800. From here to here, this is about 64, right? So 6 degree changes. The bending moment were from 800 to 0. How about Chinese night eye? 7 degree of 6 degree decrease, the moment change from 800 to 700. So still have 700 bending moment on correcting teeth. So that's much stable than stainless steel wire, right? It means if you use stainless steel wire, you need to react the wire. But for nighttime, you don't need to change. You still have 700 moment on tooth. Why is continuous light force needed in physiologic anchorage control? Because the characteristics of physiologic anchorage loss is slow and continuous mesial tipping of molars, with an average mesial moment of crown about 1 millimeter per year. Now, how many millimeter per month? Divide by 12. Well, it's difficult. Let's divide by 10. It's easy, right? So that's 0.1 millimeter per month. If we divide it by 12, it's less than 0.1 millimeter per month. So we don't need much force to resist this small amount tipping forward. Now let's compare pass with other technique, tip-back bend. For example, the back technique. Do you know what degree is the tip-back bend on 016 Australian wire in back first stage treatment? 30 degree. What degree is the tip-back bend on stainless steel rectangular wire in tweed technique? 10 degree. But it's a very thick rectangular wire. But in pass, we usually use 0149 tie wire in minus 25 degree tip-back tube. So it's much lighter than conventional fixed appliance. The advantage of the night force is it can provide continuous light movement. But you may ask, what's wrong with those bigger moment? Well, the bigger moment from the anchorage perspective, it's okay. But think of the reaction on incisors. If the tip-back is big enough to tip-back molar, the incisors will be what? Flare forward, right? Flare labially. That's why in back technique, you need class 2 all the time, from the very beginning. In tweed technique, you need J-hook headgear all the time. But if we use this very light moment, you may also think, will that flare incisor forward, right? Let's look at the study by North Carolina. In 2015, I visited North Carolina University and gave a lecture about PAS there. After that lecture, they are interested in how incisor moves under those very light moments. So they made this FEM model. This is XPT tube. And find molar get tip-back moment, and incisor show extrusion and lingual moment, not labial flaring force. That means in PAS system, the incisor will not flare out, so you don't need to use class 2 elastics or J-hook to prevent incisor flaring out. You may think about another wire, curve of SPEE-WIRE. Can curve of SPEE-WIRE replace tip-back tube? Well, when we use curve of SPEE-WIRE in street wire appliance, although molar get tip-back moment is good for anchorage control, but canine get tip-forward moment, right? But if we use tip-back tube like this, then canine also get tip-back moment, the same direction as anchor molar. In that way, you don't need to use lace back or tie back to pull canine back. That will have anchorage load on molar. But this way, you use tip back to prevent physiologic anchorage loss, and meantime, have no mechanical anchorage burden on molar. And canine tip back to relieve anterior crowding in the first stage. If you are not familiar with these mechanics, I show you a case. It's a canine forward tipping. You will see space here. I use tip-back tube and insert the canine slot, but not those one. After 1 month, you'll see the space from distal to the mesial. It's just like you pull canine back, right? So canine could be tipped back by moment, not just by the retraction force. Okay, that's the first lecture I want to introduce this morning. Next, we are going to some hands-on to use the XPT buccal tube. The first thing before we do the hands-on practice, the first thing I need you to do is to do some implantation. We put all teeth in dentition first, then we do orthodontics. We do implantation first, then orthodontics, okay? So you put all teeth in place except for first premolar, because we simulate for first premolar extraction case. If we are already done, you can take a break. After 10 minutes, we start the hand-on course, okay? Let's take a break.